It's not really red and blue, but, okay. So the central retinal artery occlusion. If you have an artery that is occluded, any area becomes pale. Okay? This is anywhere, okay? It becomes pale. Right? If I occlude my artery to my hand will turn pale. And there's two ways that that usually happens, is I form a clot right there. Okay? Right there. A thrombus. That's what thrombus is, right there. Or an emboli, meaning an emboli comes from somewhere else. I form a clot here, but it travels to my eye. And that usually comes up the carotid into that area, so it comes from the heart. If I do that, and I cut off the blood supply to my retina, I'm going to lose vision in that eye, right? Because it's my retina, it receives all of that, my vision, and especially my central. It's the biggest supply. So I'm going to lose a lot of vision in that eye. Okay? And you would have to get blood flow really quickly. Like if I lose blood supply to my hand, I would have to open up that artery very quickly, within hours. But this is really hard to diagnose. So most people that get central artery occlusion as a diagnosis, they lose their vision completely, permanently. Okay? Because that's really hard to get into that artery and open it up. You can try things to break down the clot, but it's really tough to do. Okay? So, sudden. Most times it's sudden. It's painless. This doesn't hurt. And it's most of the eye, because it's the big vein, or big artery that supplies that eye. What you get when you look in the back of the eye is pale. So I look back there and it's not red, it's pale. And it's not both eyes, so I can look at one eye and go, it looks real kind of this red coloration to pale. Make sense? This is an ocular emergency. Anyone who has sudden loss of vision in one eye is an ocular emergency, because it can be many different things. So how do I fix this without having a permanent loss? You have to do it within 90 minutes. Well, it took them 90 minutes to get to your office, so this is why it's usually permanent vision loss. But they can try some things to do this. If I damage tissue, that's what I want you to think about. If I damage tissue anywhere, I will get swelling after the fact. Yeah, I don't get blood flow, but it still brings in inflammatory properties. You had that lecture, right? So what happens is it brings inflammatory properties into the eye, and you get increased pressure. And so they'll try to decrease the pressure. They'll do a lot of different things. But treatment is by the ophthalmologist. You don't really have to know the treatment too much. But I just want you to understand. Sudden, painless, pale.
Painless.
Is it painful?
Painless.
Oh.
It is different. It is different. Or something else that I know what you're talking about, but painless. Okay? If you have branches, so how would I know if it was branches? So branches are not the big one, but the little one I include, I'm going to have more spotty vision loss. But, and it's going to be more kind of peripheral areas, right? And it may just be like here, on this right eye. I just lost it in this quadrant. Crap, I lost vision in this side. Or it's, I lost vision with my right eye right here. Or I lost it, my right eye here. Make sense?
I have a
This-
question.
Yeah, no, that's fine.
Why are we draining the aqueous fluid rather than the vitreous fluid if it's in the retina?
Because the vitreous flows into the aqueous, that's the flow of the fluid, and so that if you increase the pressure there, that's when you can get to that. And two, it causes severe damage in the anterior part of the eye. Okay, so this is an example of the central, because see how pale this is? And then what happens is the fova goes red. Remember it was white in a normal looking eye? But now it's real pink or red versus this pale coloration. Okay? That's kind of an example. All right. Vein. When you think of vein occlusion, what I want you to think about is someone who has varicosity. I just want you to think about that. And I want you to think about the back of their leg. If someone has this, I mean no disrespect, but I want you to get a visual on this. I want you to think of their varicosities, and I want you to think of, you know how tortuous it ends up looking, and they a lot of times have bruising in the back of the leg. They get little superficial vessels too on the vein. Have you seen that? Is that a picture in your mind? If not, kind of look for it this spring, because it'll help make some sense. Okay. A vein occlusion is usually from systemic problems. So if a vein gets occluded, it happens for a couple reasons. A vein's laying here, right? And it's real big, it's really dilated. It's not a good vessel anymore because I have hypertension and diabetes and it's just a bad vessel. Remember, think of it, bad vessel, they look bad, right? They don't work good. The valves in them actually that kind of open and close, that move blood, don't work. So the blood kind of pools in certain areas, right? Make sense? Or in the eye, the arteries are so hard because of hypertension, they squish the vein. And when they squish it, if I occlude a vein, guess what's going to happen? It's going to balloon up, or it can rupture. Okay? So this process is kind of happening. So what happens is you get this happening kind of all over, because it's not supplying the retina, it's just draining the blood from the eye. But if I get these little bruises all over kind of the retina, it leaves a bruise or a bleed in the back of the eye, and I get spotty eye loss. So I can't see right here, can't see here, can't see here, can't see here, can't see here. So it's kind of spotty. Or if I have glaucoma, think of my eyeball, and I just injected a bunch of fluid in it, I increase the pressure, I occlude that vein too. It's another way. So it kind of ruptures or get backflow. So that's what happened. So that's what the back of the eye actually looks like. It's called blood thunder, is what they state it as. But you can see how the vessel is tortuous. It gets occluded, you get bleeding, you get aneurysms, you get microbleeds. And so in those areas with bleeding, I can't see things there. Understand? Oh, it's so clear. I just can't see. And then when I get bleeding into an area, I get scarring, right? I get scarring, and I'm not going to regain any of that vision. So the white area is a scarring that's happened. What we end up getting is, this is really simple terms, but one of the things we try to do is we try to make new vessels, because our retina says, I need more blood flow, I'm kind of cramped, and with hypertension and diabetes, especially diabetes, it's just kind of this damaged retina. So the body says, I'm going to make new blood vessels, but they're crappy blood vessels. They're frail, they're fragile, they bleed real easy, and you get neovascularization, and you get more bleeding. So it's this kind of vicious cycle of neovascularization that it's just crappy blood vessels that the body's made that doesn't make anything better back there. So there's no real treatment for this except treating the systemic problem, hypertension, diabetes, okay? Retinal detachment. Sudden loss of vision, or a blanket fell down. So it's like a curtain came down in one eye. It's usually one eye. If it happens in one eye, it's likely to happen in the other eye. You're at risk of it happening in the other eye. It may have started as flashes of light, because usually there's an underlying cause of retinal detachment. We just talked about if I get retinal bleeding, I'm damaging that retina so it can detach. If you have one, it's going to happen. It's highly likely to happen again. If someone comes in with floaters, that can be a sign of it. Make sure you send them to the ophthalmologist. So it's a precursor of floaters. That's a picture of retinal detachment. So this is it coming down right here. This is good retina. This is the detached retina as it's layering off. This is retinal detachment right here.
I have a question.
Uh-huh.
From the branch retinal vein occlusions, if neovascularization is taking place, is it also angiogenesis taking place over there?
Ask me the question again so I know what you're asking.
So if neovascularization is taking place, is angiogenesis also taking place over there? How would you differentiate it?
You can't. I'm not sure how you would actually. It's a term used for in an eye, usually for a diabetic eye. It's the severe stages of it. And I'll show you, as we go on, I'll show you pictures of it. So here's the retinal detachment. Okay, macular degeneration. There's two types you need to know, wet and dry. It is the leading cause of blindness. It's bilateral. It's as we age, you see this, and it causes central vision loss. Central vision. Macula gives us central vision. And that's how people continue with their macular degeneration, because they can actually see in the periphery. They can't see straight ahead, but they can see in the periphery. It's hard for them to see at night. So the dry, okay, is the most common. It's about 85 to 90% of the population has that. You get like a debris, or they call it drusen, that's put down over the macula. We don't know why. The etiology of this is really unknown. But it's seen actually in, it's familial. We see it in families. It's a risk factor. Wet or neovascular or exudative, okay, age-related macular degeneration. Usually it happens earlier to younger people, and it happens quickly. It's not a slow progression, it's a quick onset. Quick and severe, quick and severe. So macular degeneration, that age-related, the dry is kind of slow, progressive over years. Wet is days, weeks, but not like what we see in most of the population. This is wet, so it's wet because it's like bleeding or exudated. This is real hard. It's a drusen, and that's what most people have. And that's the progression of vision loss. This is very debilitating.
So in most vision loss, is it just blackness like this, or is it like the other picture where the eye tries to kind of compensate, you just get like blurry?
They don't see anything. It's complete loss. So it's a blurred image, it's a complete loss. It's not a refractory problem, it's a blurred vision. Because there's no ability to, when the picture comes in, it's hitting there. There's just no interpretation of it at all.
So that first picture is just like the very beginning or something? See, it's just like
Yeah,
very-
that's not what they're seeing at all. I mean, it's hard to say. It's not like, what you get is they can't see it at all, as in like, I don't know if blurred is the right way, but if you put something right there, if you could have some, they cannot see, there's nothing there. It's not even blurred. So I don't know if the interpretation is they see this, because I don't think they do at all. There's no image there. So even with like a, when you get peripheral vision loss, you don't have an image at all. Sometimes you have blurred, but most of the time it's gone. It's a deficit.
Because I've had like an ocular migraine before where it's just like pieces of my vision are missing. Like I just don't see it,
Right.
but it's not really a blackness, it's just not there.
Yes, that's exactly, it's just, I don't think they see black. I just think it's just not there. There's no interpretation. I don't know if black's even right, but that's not even right. Word to use. Okay. High risk in women, but it's in both. So the treatment for it, we're getting better about it. They do injections. It has helped a little bit. Eye injections. Sunglasses, actually we're all supposed to wear sunglasses now, all of us. It's supposed to help reduce the risk of macular degeneration, so start wearing it outside today, this weekend, especially it's supposed to be so nice. Antioxidants, so everyone who's diagnosed with macular degeneration is on antioxidants. And we can slow the progression, we can't reverse the progression. And we can't stop the progression. All right, glaucoma. You have to know two types of glaucoma. And glaucoma is pressure in the eye, to start with. Okay? And I talked about the fluid goes from the posterior to the, this is the flow right here. And if you don't fix the glaucoma, right, it will lead to blindness because it compresses your optic nerve. It ends up damaging your optic nerve. So that would be bad, right? It's kind of the whole vision deal. Okay. Open angle and closed angle. The open angle has to do with the anterior aspect of the eye. So the angle part has to do with the anterior part of the eye. So the people that you know that have glaucoma, every person mainly that you know that has glaucoma that takes drops to keep their eye pressure down that you've heard about, it's open angle. It's as we get older, the pressure slowly increases, but it's open angle. Closed angle or acute angle is an eye emergency. It's bad, it's painful, it's terrible. So you've heard lots of glaucoma. People have glaucoma, it's not a big deal. It is, but it's not like a medical emergency. But a closed angle is a big deal. They hurt. It's totally different. So, I want to watch this. We're going to watch this about done. Getting close. Great time for a video. No, that's not it. It's a video. Oh.
Inside the eye are two fluid-filled chambers. The intraocular fluid, or eye fluid, is responsible for maintaining the correct amount of pressure inside the eye, which keeps the shape of the eye intact. This fluid is clear and watery in the front, or anterior chamber of the eye. The larger back chamber, or posterior chamber, is filled with a thick, jelly-like fluid, which is referred to as the vitreous humor. The clear and watery eye fluid in the anterior chamber is called the aqueous humor, which is continually being formed and absorbed as it flows through the eye. This fluid is formed near the lens, flows to the front chamber of the eye, and then drains into the venous system through a tiny drainage duct. Glaucoma, which is a common cause of blindness, is a disease that affects the drainage of the aqueous humor, causing pressure to build within the eye. There are many types and causes of glaucoma. Often, glaucoma occurs when either a sponge-like meshwork that filters eye fluid becomes compacted and prevents fluid from entering the duct, or when the iris of the eye covers the canal opening. In either case, The accumulation of fluid within the eye creates pressure that pushes on the back of the eye and damages the optic nerve. This nerve is responsible for transmitting the images to the brain. Over time, the increased pressure can result in blind spots and even total blindness. Appropriate therapy can halt or slow disease progression, but cannot restore lost vision.
There you go. Nothing else to teach? Yes.
So I was under the impression, like yesterday in physiology, she mentioned the vitreous humor, what you're born with is what you always have. And that was the posterior chamber of the eye. So I didn't, how is that the case if there is a channel for fluid to leave the anterior chamber to get into the posterior chamber? Is there supposed to be a way for that fluid to move? Otherwise, why wouldn't the vitreous humor just drain?
Fluid moves from the posterior into the anterior and then drains out that through the venous system. So I guess I don't-
Is the posterior chamber not the same as the place where the vitreous humor is? Is that something different?
the
Isn't
posterior.
there a vitreous chamber and posterior
There's two
chamber?
separate.
And then, I had to look that up last night.
There's anterior.
There's actually three different, right?
Yeah.
Okay.
Because in that video, it made it look like fluid was going into the where the vitreous humor was.
Back
Is that, so it is going, the fluid then is going into the big area?
I don't know. I guess I'm confused now.
Does anyone else know what I mean? Like,
I think it's because it'll only go back that direction if there's so much increased pressure in the anterior because it's not draining that it forces it back there. Like it has nowhere else to go.
And the vitreous humor is like jelly-ish, so it's not gonna drain.
So the vitreous humor can't go into the anterior chamber. There's like a posterior chamber to the anterior chamber, and it's formed in the posterior part of the anterior chamber. And then
okay, I was
goes
just
into the
wondering
front.
if there was even supposed to be a channel between the posterior chamber and the,
Oh, no,
place
no,
where
no.
the vit-
Yeah, you're right. So what happens though is okay, so it goes from here into the anterior, right? And then drains out. If you get pressure in the anterior chamber, right? It will push back into the posterior aspect of the eye, the posterior. And that's what increases the pressure. When we put eyes in, or put drops in, it decreases the pressure here.
so it's not actually any fluid flowing into
No.
that area, it's just pushing.
I don't know. I'm gonna have to look that up. I'm confused.
Because it seems like the fluid would be
This-
able to go
this
past
is-
the suspensory ligaments.
Yeah.
They're just little strings, right? There's not like a barrier there.
Let me find that out, 100%, because I was under the impression there was fluidity, or whatever is the right word, that you had. I don't think this is a completely closed off system, but maybe it is. I mean, they don't mix, but I don't know. I have to find that out. I
Okay.
don't know that.
As an offshoot to
Yeah.
that, I also wondered if you have a fixed chamber at the back and you're not congenitally short-sighted or long-sighted, then does the eye actually reduce in size?
Like longitudinally,
Yeah.
I don't think the globe itself, but it puts pressure, like, I think it puts pressure on this sac here, like if that closed system, it may be completely closed. I don't figure that out. I thought it was that the increased pressure was here. As the fluid builds up, it's a continuous system and the fluid increases here. The vitreous fluid increased. But I think it's this closed system actually pushes on the optic nerve.
Are you born with the only amount of vitreous humor that you will have? It's the anterior that gets replaced continually?
That's what
That's what
driving
we're-
yield
yeah.
is.
Okay, then it is a closed system, okay. Okay, so you have, because this is closed.
Well, if it's closed, has the vitreous humor draining into the aqueous? It's not.
Okay, how about this?
She confused the vitreous with the posterior.
How about I find out 100% and we quit guessing at this? Let's do that. How about I find that out? Because I know how, this is what I can tell you. I know how they both work and what causes them. But I don't know if it's a transfer of fluid into this that causes it, or it's increased pressure against a closed system, which is completely two different things, right? So let me find that out. Not that it's a test question, but I think it's important, okay? So let me find that out. Okay, but this is how they both work. Obviously, glaucoma is the second most common cause of blindness. What happens with, let me make sure I get to the right one. I'm gonna come back to that in a minute. Normal, you don't have to know about normal pressure glaucoma, but it's glaucoma with optic nerve damage with actually normal pressure. But it has all the same resulting destruction as glaucoma. But anyways, you don't have to worry about that. Okay. Open angle. Okay, open angle, which is the most common cause of glaucoma. This area is open. The anterior chamber, this angle is open. But the drainage is not appropriate. So the fluid increases in the anterior chamber. Resulting in increased pressure in the posterior aspect of the eye, the posterior chamber, compressing the optic disc, an optic nerve, resulting in progressive eye loss. Okay? Most people do not know they have this. It's asymptomatic except for this vision loss that happens. Okay? Acute. But what you'll see is closed angle, but I want you to think acute, closed, acute, closed. It happens sudden, okay? This angle closes off. And so it can't drain. And it's very painful because it's now. And it affects the iris, the middle chamber, the middle area. The iris is affected in a open position. Just push it open. So it's dilated and fixed. It can't move because of pressure. If your pupil is open, you're very sensitive to light. So you're in photophobia, and they have headache. Eye pain, light sensitive.
Is there a trigger that would cause the iris to protrude or close the angle, or does it, what would
People who
cause
have a narrow eyeball.
it? So just like one day it just snaps over and closes the angle?
That's one of the reasons. It's usually in females, younger females.
Does this have to do with when you like touch that penis your eye doctor?
That's exactly how they measure pressure.
Okay.
Yeah. Okay? So, I'm gonna go back a minute. That's the difference between the two. When we look at normal eye pressure, it's around 15 when you measure it with a tonometer. When we look at the disc to cup, so this is the optic disc and the cup. When you see these two things, the optic nerve running through the cup. This should be half of the diameter of the disc. Okay? So this cup is half of the distance across the disc. When we have glaucoma, remember the pressure is increased in that globe and it squishes the optic nerve and that area in. And so what you get is the cup and the disc. This is about, I mean, it's like, here's the disc and here's the cup. So it's pushed it down and it's not 1 to 2 anymore. It's just about 1 to 1 there.
So it pushes down on the disc.
Yep. Pushes it in because of the pressure. And by doing that, by pushing on the blood vessels that feed the optic nerve, I put pressure on the nerve and I damage it. So I lose my ratio. So we start to lose peripheral vision and then we lose central vision. Kind of, that's the progression of it. And that thing that they do on your eye, when you go see that, do the eye exam, that puff of air, it's tonometry to check the pressure. One of the ways they can do it. Check visual field, because you lose your visual field to start with. So you'll have, and it's equal peripheral vision loss. So it's equal all the way across. In one eye or both eyes. Okay? Here's another example, open angle, closed angle. Open angle, everyone has, older people, most common. So, shorter eyeball, other eye problems. I already talked about that, visual field loss. Cup to disc, this is glaucoma, this is glaucoma. This is what you're looking at when you use the ophthalmoscope. Greater than 1 to 2, right? How do we fix this? Well, depending on what, if it's acute or closed, or open or closed. But open, you use drops. Acute, talked about this, sudden onset of pain. Cataracts is a risk factor. If I dilate the pupil, it can trigger it in some people if they already have a shallow anterior chamber. So, check if I'm gonna dilate an eye, is if they have a shallow anterior chamber already. Because I dilate them, I've just dilated it and made that angle go really short. I would just close that angle off when I dilate that eye. I have to think about that function. How can I check your chamber depth? But if I put a light right here, the light should shine right through your anterior chamber and hit your nose. Someone who has a real shallow anterior chamber, it won't shine all the way through. So that's one of the ways you can measure someone's anterior chamber if you're just in the clinic. Not that you'll ever dilate anyone's eyes, more than likely, but you might. This is the best test question ever because it involves the pupil, got a lot of symptoms related to it. This is a acute glaucoma ankle closure. I'm using these terms because I want you, they're on boards and tests, they use them. You need to know they mean the same thing. It's kind of a cloudy cornea looking behind the cornea. It's kind of a little bit irregular and it's dilated. So it looks different, the two eyes, if you saw them. The pupils are different. Where are we at? How many slides I got left?
We're at 167.
Where do you want to go? Let's talk about diabetes. Retinopathy, retinal diseases associated with diabetes. This is real quick. This is the most common cause of young people, okay? They have diabetes and they lose their sight because their diabetes is uncontrolled. The way to prevent this is control your diabetes. All right, let's talk about this. Spotty vision loss. Okay, that's what they get. Remember that I talked about the occlusion of the venous system? This is, think of this as the exact same thing. That's what I'm talking about. Okay? They get spotty vision loss. And this is just some really specific pictures of it, but these microaneurysms that bleed, okay, they scar, okay, you get exudate put down because of the inflammatory process. You get this. Let's see. This is scarring. This is the neovascularization. So these are new vessels that are tortuous. They're frail. They bleed. That's very classic in advanced diabetes. There's two classifications of diabetes: non-proliferative and proliferative. And what's the difference between the two? Well, early onset retinopathy of diabetes is non-proliferative. There's no neovascularization. When it becomes proliferative, it's when you get neovascularization. That's what you need to know. Okay? Bad retinopathy is proliferative retinopathy. It's bad. They're going to lose their sight. It's bad. It's bad, bad. These are, just again, these are pictures that you will see in a diabetic eye. Hemorrhages, cottonwool spots, nerve fiber layer infarcts. Remember, tissue dies. When it's dead, it infarcts. Ischemic What's the difference between ischemic tissue and infarcted tissue?
It has no blood to it.
True. But ischemic tissue, you can get blood back to it. So ischemic is low blood flow to it, right? But you can reverse it. Infarcted tissue is dead tissue. So terms that you see in retinopathy, Cottonelle spots. That means infarcted tissue or nerve fiber, I don't really care. Microaneurysm, dot blot. What's a dot blot? Just little tiny bleeds. What's the difference between a dot and blot? Just the size. Do I care? No, it's just a dot blot. It's just what they call it in the back of the eye. So exudate, Cottonelle spots, microaneurysms. Still, this is a very progressed retinopathy. Microaneurysms, dot, blot, exudate. It's retinopathy, diabetic retinopathy. You should send any new diagnosis of diabetes to the ophthalmologist, okay? Type 1 or type 2. And then how they follow up is depending on where they're at in their disease. How do we treat it? You guys you'll learn about this in diabetes. Control your diabetes. This is a great picture just of the proliferative or neovascularization. See all those tiny, cracky blood vessels in there. You also got to think if that is the vessels that are supplying blood and taking blood away from the retina, it's not getting anything. And so retinal detachment is what's more than likely going to happen. They go in and they laser those, they destroy all those, and then tack down the retina. What's the difference between diabetes retinopathy and hypertensive retinopathy? I would just take a guess. Do what? Yeah, I mean, person with hypertensive retinopathy has hypertension. Diabetes retinopathy, they have diabetes. That's the difference between the two. It's pretty difficult. You usually don't see neovascularization with hypertensive retinopathy, but it's hard to distinguish. So if someone has diabetes and hypertension, which one do they have? They got both, yeah. It's pretty crazy. Yeah, it's difficult. What you can though see a lot better in a hypertensive retinopathy is the arterial disease. And we look for certain things. It's called AV nicking, copper wiring, silver wiring. This is really kind of fun stuff. This is just fun. I love this part. I know, but I love it. Okay, so if you remember I talked about a vessel or a vein that's real thick and not very good anymore. And then you get an artery that's thick because it's hardened. You've heard the word hardened arteries, right? And it sits over a vein and it kind of squishes it. That's called AV nicking. And you can actually see that in the eye. So that's why we say the eye is the window to other diseases, because if it's doing it in the eye, guess where else it's doing this? All over, right? So that's AV Nikki, I'll show you a picture of it. If you take a vessel, an artery, and it's got thick walls, right? And you shine light through it. If I narrow it because of plaque buildup, if I narrow that artery, when light shines through that, as I look in there, the reflection is greater, so actually I see more light coming back at me versus a vessel that has a wider opening. So this is normal, and this is diseased. And I look at this person and this is their artery, and it's real narrowed. The light shines back at me because it's narrowed, and I see silver wiring, copper wiring. And that's what this is. This is their artery, okay? And that's what silver and copper wiring is. It's narrowing of the arteries.
We can see this by just shining a light into their
Yeah,
eyes?
you can. It looks like silver. You shouldn't see silver in the back of the eye. Yeah, because of the reflection. When you look into the back of the eye, the darker blood vessels, the darker blood vessels, the vessels that you see, this is actually the vein. The venous system is darker, and they're wider. That's normal. Arteries are thinner and lighter when you look at it with the light. They should be close to the same, but arteries are a little bit smaller. But as the arteries really narrow and the veins really swell up, because remember they get venous insufficiency, so the venous system gets bigger and the arteries seem to look like they're getting smaller. That's another thing that's going on. That's disease. Right? Venous congestion, they dilate. The valves don't work very well. Blood backs up. So this is a great picture of silver wiring. Silver wiring. What you also get, this is nicking. The artery is sitting over the top of that vein. That's AV nicking. That shouldn't happen. Even though they cross over, an artery should be heavy enough that it compresses a vein. Because arteries and veins cross over all the time, but they shouldn't compress. That's what AV nicking means. See how this is the vein. This is the artery. See how thin that artery is and see how dilated that vein is? That's abnormal. That person has hypertension. That's the start of hypertensive retinopathy. That's going to aneurysm itself, start to aneurysm or bleed, get leaky vessels, and you'll get little dot blots and stuff like that. Flame hemorrhages. They flame out because it depends on the layer in the back of the eye where it's at. It looks like a flame. Hypertensive emergency can cause retinopathy. As blood pressure shoots up immediately. We never diagnose a hypertensive emergency or crisis just by the level of blood pressure. So 210 over 100 isn't by itself a hypertensive urgency or emergency. You have to have some systemic result, like retinopathy. If you have retinopathy associated with that, all of a sudden, that's a hypertensive emergency. Or you have renal insufficiency because of it, that's a big deal. We'll talk about that in a minute, or after break. How do we treat this? fix it. Should we break? Should we stop? Should we keep going here? You wanna keep going? How much do we have? We're on 90.
17 minutes.
Let's break. Because it was like